It's a little better, but it'll work. You can see it's coming out, so it's not as perfect as it should be. But you can usually see you want to try to see if you can get that. Anyways, it'll come out good. So anyways, so there we're good. I'm going to just go ahead and turn this off for right now, like that. Okay, so now the other thing I have to do is get my sterile equipment ready, because once I put my sterile gloves on, can I touch any of this stuff?
No.
Nope, I cannot. So I'm going to prepare my sterile field. Thank you. Can you move your, please? So, however, with whatever area you have, sometimes you have more area than others. I am going to open all these, but I'm not going to touch anything on the inside. And as long as you don't, it's still sterile. So I can do this. And make sure you know which one's fenestrated and which one is not. Because it will become apparent to you why you need to know that. So see, I'm opening like that. I'm not touching anything there. That like that. I'm going to open this away from me, and I'm just going to pull the top off, and I'm just going to leave it like that. I'm going to open this.
This is all on your own, correct? No one's no assistance, so no helping from your partner.
When you're checking off here, you will do it completely by yourself. Whether you have help or not at your site will depend.
How much time will we have?
As much as you need,
2 hours.
within reason. If you're fumbling along, you know how I am. If you're fumbling along, I'll know. And then my little chlorhexidine ring.
And we'll be opening it on that.
That's where it's going to go, yeah. Okay, so now everything's ready. So now I'm gonna put my sterile gloves on. So at this point, I would go clean my hands with something that's called Avogard. That's sterile, so we go get that. It's got the little foot pump. Pump it in your hands. You're gonna do this with your nails, like this with your nails, then your hands and your fingers and all in here, and then all up in here, okay? And now, T-Rex comes into play. You'll learn this more next week from Miss Lewis, but this is considered like, if I'm like this, people know my hands are sterile. When you're in a sterile gown, this is the sterile. It's like a little box. It's in, don't ask me why, it's just the universal sterile signal that this is our little sterile area. Anywhere out of there is not sterile anymore. So I was supposed to open these two, but I didn't. So I should have done that before I Avogard. Sorry. Yeah. So, all right, we're gonna say.
And you're not, but you can touch the outside of the.
She's sterile right now.
Right.
Yeah, that wasn't a sterile. I should have opened it, and then I could touch them.
Okay.
Yeah, I would have had it ready.
Sorry, I sneezed.
But I didn't. Yeah, I know. I should have opened those when I opened everything else, because that way I could touch them from the inside the packet. So had I done this the way I was supposed to, these would be right here, and this is now sterile, so I could take them and grab them like this.
Are you wearing gloves when you're opening everything up, or does that matter?
You don't have to. So, because that's all just equipment, so you're not touching anything with the patient. So I'm going to take my gloves and I'm going to open them up. Sometimes we make a little tent here to keep them from closing. I'm giving myself a lot of room here. And then, that's good, thank you. I'm going to take one, and I'm going to, I'm just holding it right here, you guys, because I can't touch anything else because it needs to be sterile. And you'll need to figure out what size you wear too. Anyone can compare to me. I wear an 8.5. They're a little bit big, but the 8s are too small. So I'm gonna do this like this. Then I can touch this one because I'm sterile now, but really you wanna just take it like this. And then I'm gonna take my hand and put it in like this. And I'm going to pull this out so I make sure that it doesn't touch any part of my non-sterile skin, because it's the inside. And then once I do this, I can readjust a little bit like that, okay? So now I'm sterile. So now I'm gonna take my non-fenestrated drape, because that's gotta go there, where your arm is. So you're gonna take this drape and you're gonna pick it up like this. And then you're gonna take a corner like this, and then you're gonna grab the other corner like that. Everyone asks me why I can't touch all of it, because I'm sterile. You can't, it's just the way it is, okay? And then you're gonna place it here, because this is my sterile field. Anything off the edges is not sterile. The sterile part is considered within this field, usually about an inch off the side, from the outside, okay? Now I can place all of my sterile items that I need here. So I can either take that, I can take this, I can take that, and I can take these items, because I can touch the inside because that part is still sterile. No. And everything's there, okay? So now I have all my supplies that I need there. I'm going to take the next drape and do the same thing. I'm gonna put it up on a corner, get the other corner, and I'm going to put it over the site. Can you move that for me? Thank you. Don't worry if stuff falls on the ground, it doesn't matter. And I'm gonna place it over where I'm gonna insert my art line. Then I'm gonna take my needle. Remember, we're not using this one. So if we have our other packages, pretend just for showing you guys, if you were gonna take this one, then you would open it like this, lay it down, and then you can put your stuff up there. When you guys do closed glove technique, you're going to use your sterile field from your gown, and you'll actually dump things on your site before you get gloves on. So it's a little bit different this way. So now I'm ready to go. I'm ready to put my line in. So can we turn on our little pump here? And so now the pulse isn't fantastic on these, but you can see where other people have stuck. Yes. And then this is for technique especially. And so I'm gonna take my needle, bevel up. Now for an art line, let me put my glasses up because they're falling off my face. So
that's real hospital life.
Yeah, that's what you do. I can't touch my face because I'm sterile right now. So, or I might say, I'm sweating, give me a towel. Okay, so bevel up. Now, ABGs, we go like this. Art lines, we're gonna go more like this because we need the catheter to go into the artery and it's gonna stay in there. So we're not just going in to do a stick and get blood. So you can either do it like this, or sometimes the technique is to do it like this so that you're going at the right angle. But remember, not like a ABG. So I'm gonna find my artery, I'm gonna go and I'm gonna stick. And you may or may not see a little flash. Once you think you're in, remember there's a needle in here. So to advance the catheter, I need to pull the needle back a little bit and then I can easily push the catheter in at that point, okay? Take my needle out, cap it, do not leave it uncovered. That's a huge no-no. Now I'm gonna take my wire. This is bloody mess. It's okay, don't worry about it. You're in an artery. We're not expecting there to be no blood. This is my wire. So you need to be careful with this wire because it needs to stay sterile. There's two different ends. One end is more firmer than the other. It's very obvious which one is which. The firmer end is gonna go into our catheter. Keep control of it, wrap it. I like to do it like this. And then a lot of times the wire doesn't just go in gently. You have to push it in. So I'll hold the catheter while I'm inserting the wire. So now my wire's in. This is plenty. You just want to make sure that the wire is going to stay in. So now I'm going to pull my catheter out while I'm making sure my wire stays in. So I kind of push the wire in more while I take the catheter out. And now, then I'll hold this, and now my catheter is out. Now I'm going to actually put the arterial catheter on. This is where you got to have good hand-eye coordination. You're going to put the catheter over the wire. So the wire is going to stick out the other end. Now I'm going to insert my catheter in. On a real patient, thank you. On a real patient, you might have to give a little nick there to get through the skin. On this guy, we don't have to, so now I'm going to push my catheter in all the way like that till it's at the skin, and I'm going to pull my wire out. Blood splurting everywhere, so now I'm going to hook up my line like so, and I'm going to open it, and I'm going to flush it because I need to make sure it flushes so I know it works. So, and you can usually tell if it's flushing because you can see the bubbles move. So you can see we're flushing, even if it's not perfect. So, like I said, it all works, okay? Now, I'm going to rip this. Don't worry about that. Chlorhexidine ring, this is to help prevent infection. It has a little slit in it, but we're not going to be using that because if you put the slit around it, if you have to change the bandage or change the ring, it sometimes will pull the catheter out. So it's literally just going to sit on top like this. And then we would put our tegaderm or whatever it is we're going to use to hold it in place. Opsite, I call them sometimes. The other thing you'll do is take the transducer line and wrap it around like this to help hold it in place while it's on your patient. Okay? The transducer has to be at the level of the heart. So they have a little place where this will sit on the actual IV pole. Why does it have to be at the level of the heart? To get an accurate reading. The reading is inverse, so if the transducer is too high, your blood pressure will be lower than it is. If it's too low, your blood pressure will read higher than it is. Sometimes they trick you and they say, the bed was moved. So the transducer is fixed to a pole. Housekeeping comes in and puts the bed down. The transducer is now higher, but you think down and you're like, oh, it's gonna read the opposite. So, so the transducer is higher because the bed went down, so it's actually gonna read lower than it's supposed to. It'll be a false reading. If the bed went up, the transducer went down, and so it would read higher. So it follows the direction of the bed. If the transducer itself moves, it's inverse. That makes sense. Okay, now I'm gonna show you how to, I'm gonna take this thing off because I'm dying. Draw blood. I don't have the little cap that oh, this one doesn't need a cap. Can somebody grab me a syringe? There's a drawer that says ABG syringes. By the wire? The wire will already be in, yeah.
Really right
little tiny, yeah.
When you try to put
scalpel.
arterial catheter in, you'll see where you need.
Yeah.
It's very small.
So that little,
Huh? What?
I was saying that little wire that's already with the replacement to the first catheter that you put in. Is pretty much beside the artery, right?
Yes, it is. Yep, that's where you want it. So this Artline transducer system has a little port where I can put my syringe on here. A lot of them do not, and you need a little cap that goes on there that will puncture. I know we have one back there that looks like it. And then you have to put your needle onto that. I can't remember what it's called.
I don't know, but
it's like a little claw. It's like a little claw that would puncture. So if here I've got a port. So if I'm gonna draw an ABG, we're not sterile now. Now I want my ports closed because I don't want anything in them. So right now I need to draw waste blood, okay? So right now this port is off and I turned that port off. So I can't really draw anything right now. So if I want blood to come from my patient, I need to turn the port away from the patient. So now blood would come out here because this is closed off, right?
Right.
So I'm gonna take this and I'm gonna put it on. Well, I would have done this part first. And I'm gonna draw, and like I said, it'll work. Draw my waste blood, close the port, or you'll have blood everywhere. Get rid of this in theory, okay? But we're not getting rid of it. So that was my waste blood. Now I'm gonna actually come and draw my ABG. So I'll put this back on here. The port's still closed. I open it. I'm gonna draw my ABG. I'm gonna close it. I'm gonna put my ABG to the side. Oh, clean it with alcohol too, by the way. And then I'm gonna flush my line because now I'm done, but I have all this blood here that needs to be flushed back clean, okay? If you have a vamp, you're going to close it off to the bag because I need blood to come from the patient. You would pull the vamp, the blood would go in there. You would go here, take your ABG syringe, like the vamp would be here. Take the ABG syringe, get your ABG, close the port back off, squeeze the blood back in from the vamp, and then flush. Okay? It's gonna take practice. You guys have to practice with all the stopcocks, and you're gonna have lots of practice. We have 4 arms. You're gonna have to practice doing the sterile. Troubleshooting, why don't you tell us about troubleshooting?
Do you guys know why you would want to push the blood back in?
No. It's gonna clot if it's just sitting there.
Well, rather than just throw waste away.
Oh, the waste one? You don't want them to lose blood?
Well, say it was a small person. They have very limited amount of blood. We have a lot more to give. If it's a smaller body, they have less. Or if they're running hypotensive already, they don't have a lot of fluid in their system. So you don't want to take some and just waste it every time when you're running serial ABGs. You know, you can run them every 30 minutes sometimes. So that's a lot of blood to throw away from somebody who actually needs all their fluid. Does that make sense? Okay. Troubleshooting as far as insertion or
Just in general.
afterwards?
Like if it's not working. You did it the other time. Well, yeah.
So you're gonna look for so smooth pull when you're drawing your ABGs. You could be clotting around your not Hepafix tegaderm. You might see leakage. Your catheter could have come out, especially when you get some Riley patients. We went over the transducer being up or down, right? You'll see that in your waveform.
So if you guys can't get blood, let's say you go get blood from the catheter and you're not able to get any blood out, what would you do? Try flushing the line. Yeah, if you can't, that's probably because the Artline went bad or there's a clot in the system. The other thing is if the waveform is dampened, when we say it's dampened, we mean that nice little waveform I have there, you don't see that dichrotic notch and you see it about half of the height it should be. If a waveform is dampened, there's likely to be a clot in the line or an air bubble. That's typically what makes that happen. Sorry, it's so much cooler over here. How did this pass out? Yes.
So the idea of flushing is, of course, flush to clean up the line, but is it going always back into the patient?
Yeah. If it's working right, it should always go. The idea is to make sure, if you can flush the line is working. If you can't flush it, then something's wrong.
Any line.
Yeah, period.
All of your lines. You flush to test. The nurses do it where I'm at with their picks and whatnot. They flush it to make sure before you draw a venous gas from it. And sometimes it's a positional thing.
Yeah.
So it's not just like, maybe it's a clot, could be, but it could just be that, you didn't put your arm board on or they moved just a little bit and that catheter moved and maybe it's up against the edge of the vessel and not floating in the middle. So pig lines are super positional.
So do these blow often and do you have to redo them a lot? No.
Not in my experience.
Okay.
No.
That's not impossible.
Okay.
But not in my experience, no.
Nick?
When you were inserting it, you said there's sometimes a flash, sometimes not, and then it's just...
On the arm, not on our human. You will always have a flash on a human,
okay.
not on the arm.
I was like, so you just did all that? Maybe it's it?
No. Our arms here don't always flash. But you're typically, and you can see where people are sticking. I will tell you guys, on these arms, there's a big spot right here. That is not where you stick. Think about where your radial artery is. You'll see the holes. The new one just doesn't have a lot of holes, but you'll stick where you stick for an ABG, not anywhere else on that arm. We're just doing radial arterial catheters. Any other questions? Yes.
So when you're all done and it's secured, do you leave the patient on the board as long as you have the Artline in, or do you take the board away and just let them free float?
Where I'm at, you keep the arm board.
Most places you do.
Yeah. And I don't know if maybe that would be different in adults, but in peds we always do.
And would you restrain the other arms?
Is it adults as well?
Yeah, you keep the arm board, because as soon as the patient starts doing this and all this crazy stuff, you won't get good readings anymore.
Yeah, you're gonna have a hard time keeping it.
Other questions? You ready to do them?
How many arms do you have?
Sure.
We have 4.
I have 2.
That's 2.
Hold on, we have a question, guys.
Is the arm board attached to the arm board? Can't they just move it if they want to?
No, so an arm board is, it's like a small piece of wood, like a tongue depressor, wrapped with firm cotton, right? So you put it here, and then you tape their hand, and then you tape their form, not tight, not tourniquet, but you tape it down so that board is now, I can move my elbow, but I can't move my wrist.
Where your line is.
And just like when you do your art sticks, when you kind of hyperextend, you put like a washcloth or a towel or whatever it is, small, there, so it keeps everything just like this, the position that you want.
So do we take after our Allen test, or do we take, like,
The
obviously
board?
want it done before, when the procedures, so we don't have to sterile, or when you guys usually do it?
The board is usually going to be done first.